Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Healthy Insights That Matter. The World Health Organization estimates that 537 million people globally are living with diabetes. And by 2045, which may sound far away, but really isn't, projections show this number rising to 783 million on diabetics globally. We frequently hear that obesity, a contributing factor to diabetes, has reached an epidemic proportion in the United States as well. Today, I am happily joined by an endocrinologist by the name of Dr. Daisy Dewan to discuss the highs and the lows of managing diabetes. So welcome, Dr. Dewan, and thank you so much for joining me today.
Thank you so much for having me.
So let's first launch into talking about the types of diabetes. I think that most people know that there are more than one, but not everyone does. So can you fill us in on that to start?
Sure. So I think most people, when they think about diabetes, they're thinking about two main types of diabetes that we hear about, type 1 diabetes and type 2 diabetes. There's a third common type that we do think about separately called gestational diabetes, which is typically in pregnancy. And then there are a lot of other more rare types of diabetes, including diabetes related to chronic pancreatitis or some really rare types of genetic forms of diabetes related to mutations. So going back to the more common type 1 diabetes is considered an autoimmune condition where our immune system makes antibodies that attack our pancreas, which is the organ that normally make insulin. So when the pancreas are being attacked by the antibodies, it impairs our body's ability to make insulin. So people with type 1 diabetes have high blood sugar because of insulin deficiency. They typically present in childhood, though they can present in adulthood. And usually the mainstay of treatment is replacing what they're missing, which is insulin. Type 2 diabetes is the much more common type we see in adulthood. This is the type that is associated with overweight and obesity, and it's characterized by resistance to insulin. So your body still makes insulin on its own, but the insulin you make just doesn't work as well. Your sugar levels are still elevated. Overweight obesity is one of the causes for that insulin resistance. And then, as I mentioned before, gestational diabetes is diabetes diagnosed in the second or third trimester of pregnancy. It's actually also related to insulin resistance, but it typically is not there prior to pregnancy, but it does increase the risk of developing type 2 diabetes later in life. Those are the three most common types.
Okay. How is diabetes most commonly diagnosed?
There are several different ways. I would say that the most common way is through a blood test called hemoglobin A1C. This is a marker of somebody's average blood sugar over the last 3 months because blood sugar tends to fluctuate throughout the day, throughout the month. So this is why it's a very convenient test for us to know whether somebody's sugars are typically elevated most of the time over the last 3 months. We use a cutoff of 7.5% on hemoglobin A1C to say this is a diagnosis of diabetes. There are other blood tests such as a fasting blood sugar, again on the blood test more than 126, or probably the least common test we use is a 2-hour oral glucose tolerance test where somebody drinks a sugary drink and then we check what their sugar is at 2 hours. And if that number is 200 and above, that's also diagnostic of diabetes. That one is used less commonly. That's mostly used to diagnose gestational diabetes in pregnancy.
Is diabetes particularly prevalent among people with color? And if so, why?
That's a great question, and thank you for highlighting this. So, in fact, there is a much higher prevalence of diabetes across all of the racial and ethnic minority groups. This includes African Americans, Hispanic, Latino Americans, Asian Americans, and actually the highest group with the highest prevalence of diabetes is Native Americans or Alaskan Native group. In addition to just having a higher prevalence of diabetes, These minority groups also experience higher burden of complications related to diabetes, such as eye disease or retinopathy or kidney disease or nephropathy. They're more likely to be hospitalized related to diabetes and diabetes complications. And then lastly, unfortunately, they also have a higher risk of death related to diabetes. In terms of the question why, part of the reason is that there's a lot of comorbidities that increase people's risk of developing diabetes, which the minority groups also have a higher prevalence of these risk factors. So these include hypertension or high blood pressure, includes obesity and overweight, and particularly more weight in the central abdomen, or what we call central obesity, also increased risk for high cholesterol. Now, all of these health disparities, where they come from, can definitely be related to access to healthy and affordable foods and access to preventive medical services, so that when there's even a little bit of risk, increase in blood pressure or increase in sugars, there could be preventive medications or medical therapy that could be implemented if there was access to routine medical care. Also, the time and overall access to exercise is another limiting factor contributing to these health disparities. And then the socioeconomic factors such as employment and health insurance, the medications and also access to routine medical care are all linked in with that. So all of these things we think definitely contribute to the disparities in health outcomes related to diabetes.
Though we know the estimated number of people globally currently with diabetes, as I mentioned earlier, 537 million globally, I suspect there's a lot of people that have diabetes and have not been diagnosed. Do you have a guesstimate as to how many people that could be, whether it be globally or whether it be just here in the US?
So in the US, when they report from the CDC in terms of how many people are diagnosed with diabetes, I think the most recent report is about 15% now. That's already an increase from 10% from before. And I think when they report that, it's a combination of diagnosed and undiagnosed. And then when they break that down, the most recent data shows that about 10% is diagnosed, that people know about diabetes, and then about close to 4 to 5% is actually undiagnosed, which means they only know about that through these sort of population-based statistical testing
Yeah.
based on CDC.
So that's going to lead me now into talking about what are some of the common symptoms of type 1 and type 2 diabetes, because I would suspect that some of our listeners, in hearing what you're about to say, might go, I think maybe I should see my PCP and get evaluated.
Absolutely. I do want to point one thing out before I talk about the symptoms, is that the vast majority of diabetes is diagnosed when people are in the asymptomatic stage. So just a plug for why it's important to see your doctor regularly, because a lot of times, especially if we want to catch diabetes earlier, having those routine blood tests done with your doctor can definitely catch diabetes really early, where it could be much more easily managed and before some of the complications develop. In terms of symptoms, once the elevated glucose is at a certain level that you start to experience symptoms, they frequently include frequent urination, increased thirst. And part of this is because the glucose levels are really high in the blood and they have to go somewhere. They have to get out of the body in some way, and they tend to go to the kidneys, and people urinate out extra sugar there, and then water always follows. So as you can imagine, people can experience really dry mouth and increased thirst and dehydration. That's one of the dangers. Then also people may experience blurry vision along with it, again, because of the elevated glucose levels around the fluid around the eyes that can make people experience blurry vision. Weight loss is actually counterintuitively one of the signs of high blood sugar. Part of it is that you're peeing out a lot of extra fluids. Those are the common symptoms: frequent urination, increased thirst, blurry vision, weight loss, and other signs of dehydration.
What can we do to reduce the risk then of developing diabetes?
I would say the two mainstays of reducing risk of diabetes are related to physical activity and then also diet. Really, both of those have the goals of preventing the development of obesity, overweight, or reversing right? Or treating obesity and overweight. I think that's one of the main factors in which we can reduce the risk of diabetes. For example, with physical activity, it doesn't have to be running a marathon or doing anything extreme. They could be walking or, fast walking, running, climbing the stairs. We typically say 30 minutes of moderate to vigorous exercise 5 days a week is a good starting point in terms of just getting your muscles moving. And then in terms of diet, it's more related with the goal of a little bit of weight loss. So we know that studies have shown anywhere between 5 to 10% of weight loss. So it's very individualized, right? Based on where you're starting with your starting weight. And that's typically done primarily through diet. And this could be any really healthy diet that people can sustain and continue that can induce this 5 to 10% weight loss that we've shown in studies definitely reduce the risk of developing diabetes in the future.
So I'm glad that you, in talking about physical activity, that this doesn't mean that everybody has to go out and buy a gym membership, correct? That
Yes.
this is something that they can do in their house or outside of their house, going around the block several times and maybe taking their neighbor, if they like their neighbor, with them to do a couple rounds rather than feeling like they have to go to some professional place in order to be able to accomplish this. Once someone has diabetes, what's the most effective way that you've seen for managing it for type 1 as well as managing it for type 2?
Type 1 diabetes, as we discussed before, the basis of that disease is there's a lack of insulin. So the person's pancreas just do not produce insulin anymore. So really the most effective treatment, the only treatment we offer for these patients are insulin therapy. Traditionally, there are injections of insulin, pens in the subcutaneous tissue. But nowadays, for the majority of our patients with type 1 diabetes, they can do this using insulin pump therapy. So this is a continuous infusion of insulin to the subcutaneous tissue as well, but they don't have to inject themselves or poke themselves several times a day. So it's a lot more manageable. In addition, for people with type 1 diabetes, really the changes and advances in technology we've seen have dramatically really improved their quality of life. So this includes continuous glucose monitors. So these are devices that are pretty small. They're kind of like a dollar coin size. People still know how big that is. You can still see it, but they put it on their arms. And it stays there for 10 to 14 days, and it continuously monitors your glucose level every couple of minutes and actually transmits to your phone. It can transmit to your Apple Watch. So you don't have to poke your fingers anymore to know what your sugar levels are. And nowadays, with that technology, they've now combined that with insulin pump so that the insulin pump itself, we call them hybrid closed loop pumps. The insulin pump themselves can take that information where the continuous glucose monitor knows where the sugar is going to be, and it will self-adjust the amount of insulin it is delivering to you to both prevent low blood sugar from a safety issue, and then also to give you little boosts of insulin if it predicts you're going to have a high blood sugar. So I would say for people with type 1 diabetes, the advent of these hybrid closed loop pumps with the continuous glucose monitor and the pump therapy have really made lives much easier for them. And that continues to be evolving with algorithms and et cetera. So I think that's sort of where type 1 diabetes management comes in. Now, type 2 is very different. Type 2 diabetes is characterized mainly for insulin resistance. So typically in the beginning stages of type 2 diabetes, people still make insulin, so they don't need insulin therapy in the beginning. This is where we have medications that help improve insulin sensitivity, so it makes our body more sensitive to the insulin we're already making. So we can do that with non-insulin medication. So the traditional ones are metformin, which is a pill. It really helps with insulin sensitivity at the level of the liver. And then nowadays we have these newer classes of medications, such as the GLP-1 receptor agonists. So this is medications such as Ozempic, Trulicity that you hear about in the news. And then also SGLT2 inhibitors. These are pills that also work on the kidneys to help patients pee out the extra sugar. But these medications are now really popular because in addition to treating diabetes and lowering blood sugar, it has additional benefits such as weight loss, such as reducing events related to heart attack and strokes, reducing people's mortality, preventing people from dying from heart attack and strokes, and also preventing kidney disease. So because of these added benefits of these newer classes of medications, I would say they are now becoming much more popular in patients with type 2 diabetes and to help prevent these complications and help control blood sugars at the same time.
I'm sure that our listening audience has seen some of these commercials on television, since there's a lot of direct to consumer advertising, and also seen the devices that you've been talking about too, to see what they look like and how people are jumping in their swimming pool or doing whatever that they're doing, sitting down in a restaurant and checking their numbers before they decide what they're going to order for dinner. And each time I see those, and I go, hopefully there's a lot fewer people having such a low blood sugar that they could jeopardize their life, or having such a high number they can just fall over and go to sleep or go into a coma, because those were certainly two things that we always worried about, was the numbers being too low and going into the hypoglycemic stage of actually going into shock, or going to sleep and then unfortunately remaining that way. And it's good to see that the pharmaceutical companies are making the effort to find new drugs to make this more manageable, so that people can live in harmony with their diabetes rather than it monopolizing their life. What are the potential consequences of not taking diabetes medication and enabling their blood sugars to go too high? And as I mentioned, one thing, a diabetic coma, I think, would be the worst case scenario. But you've also talked about heart disease and other similar, what I'm going to call comorbidities. Can you talk about that a bit more?
When people's blood sugars are very elevated, I usually list them out as what are some of the dangerous things that could happen like right now? And then what are some of the dangerous things that can happen long term if months to years of uncontrolled diabetes. Short term, right, with the blood sugar being high, it goes into what you talked about, the diabetic coma. So a lot of it is because of the dehydration component. People are hospitalized because of it. There's also infection risk. When blood sugars are really high, it can impair how our immune systems work and fight off infections. So you're more prone to infections. And then when you do get an infection, it may take you a lot longer to recover from that. Those are the more what I call acute effects, what can be dangerous right now for elevated blood sugar. In terms of long-term effects over months and years of uncontrolled diabetes, these are what we call complications of diabetes. So they fall into two big categories. Basically, they all affect blood vessels because you end up having high blood sugar, and blood affects the entire body. So you've got large blood vessels and you've got small blood vessels. The large blood vessels are the blood vessels that feed into the brain. So this is where people can have strokes if their blood sugars are uncontrolled for a long time. Large blood vessels also help pump the heart. This ends up being heart attacks if the large blood vessels of the heart are affected. And then the third large blood vessel is the vessels that feed into the lower limbs, the legs. So this is what we call peripheral arterial disease, where people can have decreased circulation to the legs and wounds at the feet, etc. So those are the large blood vessel complications. Then we've got small blood vessels. So these are the blood vessels that go to your eyes. And so one of the complications is retinopathy, which can lead to blindness. And I believe diabetes is one of the most common causes of blindness. In addition, there are small blood vessels that go into our kidneys. And this is why long-term people develop kidney disease and end up on dialysis because of diabetes. And then lastly, our nerves, particularly our peripheral nerves of our hands and feet, they can be affected by small blood vessel disease caused by diabetes. And this is where people can have neuropathy, where they have numbness, tingling. They may lack sensation to the feet, so they may not know that there's a wound or a cut, and then they continue to use it. And then that gets infected. And then this is where people hear about people having foot amputations or toe amputations. And that's usually related to neuropathy. Those are all the complications and where diabetes can really affect many different aspects of your body.
I'm sure that many of the women listening to this today are thinking about where they go for manicures and in particular pedicures. Can you offer some instruction and advice about what they should be watching for when they go to get that pedicure?
That's a great question. I get that question a lot from my patients with diabetes as well. If somebody has diabetes, they should definitely be very careful about particularly pedicures, Part of it is that what you're looking for is open wounds. Like if you have an open wound or even like a cut or something on your feet, I do recommend avoiding getting a pedicure when that is there, mainly because it's an entryway for infection and you really don't know how clean a particular nail salon is or that particular person that's doing your pedicure. In addition, like even with nail cutting, some of my patients with diabetes, particularly if they already have neuropathy, they only go to the podiatrist for nail care, just because a lot of times I think in the nail salons, they could cut too close and cause a wound, for example, even if you didn't go there with an open wound. So I definitely agree with being very, very careful if you have diabetes. Maybe asking for things that are a little bit more gentle as opposed to some of the more involved services. And I also think that routine care with podiatry is important if you do have nail problems, etc.
I always tell people pay attention to where they're putting their instruments when they're done with the person sitting next to you. Do they just drop them in the sink and rinse them and then they come over to you? If they do that, get
Right.
up,
Yeah.
get your shoes, and get out of there.
Exactly.
Please. Right? Oh boy, oh boy, oh boy. Something we haven't touched on yet, but I do want to include it today. And I'll give an example of it. My late mother-in-law was one of 14 children, all single births, and all survived, if you can imagine such a thing. 10 of the 14 developed diabetes. Their mother was a very brittle diabetic. And then in turn, these 14 had families, right? So my husband is one of 3 sons. My mother had 3 children. All 3 have diabetes. So what is the frequency with which this is a familial disease? This is a hereditary problem. And how should we coach the mothers who are out there who don't know that their teenage son is voiding more frequently or has a dry mouth because he doesn't tell anybody anything because he doesn't think that's important?
That's a great question. I think that the answer is different based on the type of diabetes they have. Surprisingly, we think of type 1 diabetes as this is the autoimmune condition where people cannot make insulin. So typically people present in childhood. For that one, there's definitely a genetic component. If there is type 1 diabetes in the family, then each subsequent family member has a pretty increased risk of developing the same type of diabetes. But this type of diabetes is rare. And there's actually screening programs out there now as part of large research consortium studies where if you have a first degree relative who have type 1 diabetes, you can be enrolled in these consortium research programs where you can get the antibodies checked for you, even before you develop type 1 diabetes, for example.
That's great.
Yeah, because of the increased risk. And what's most exciting is that this year, for the first time, there is actually an FDA-approved medication that can be given if, let's say, you've got the antibodies for type 1 diabetes, but you don't yet have symptomatic high glucose levels. There's a medication called teplizumab that can halt or delay the onset of type 1 diabetes by an average of 2 years. Before, if you get screened and you just kind of know, but there's nothing you can do about it, right? But now this medication is actually approved. And then I think there's more on the pipeline, but that's more in a research setting. For type 2 diabetes, this is where there's actually a huge genetic factor or heritability factor in type 2 diabetes as well. But it's not quite as simple as in type 1 diabetes. It's what we call polygenic disease. So what that means is it's not like there's one gene that we can say, oh, you have this, you're going to have type 2 diabetes. It's not one of those diseases. It's polygenic, which means there's probably a variety of genetic predisposition or risk genes that you could have. That could be multiple. Just because you have it doesn't mean you're going to develop type 2 diabetes 100%. It might be a very small percentage, but it's the combination of maybe a couple of these risk genetic makeup plus some lifestyle factors, right? Such as the development of overweight, obesity later on in life, and some of the diet and physical activity behaviors later on in life. And it's combination of those that then people then develop type 2 diabetes in their 50s, for example. But there's a huge genetic component. We do know that it runs in the family, even more so than sometimes type 1 diabetes because of how common it is. And so
Right.
particularly it's not just parents, it's grandparents, right? Your aunts and uncles. It really runs generations. And I do think that it really signifies the combination of both the true genetic component and then also there's a lifestyle component that the family may share as well.
Before we close, I want to also ask you about what is happening in the area of research. What's being studied, particularly in the lab? What are we learning and what do we hope to learn?
There's very exciting research happening. So in the type 1 diabetes research world, there are more immune system based therapies now where people are trying to either delay or reverse that autoimmune process that really is at the basis of type 1 diabetes. So as I mentioned, this FDA approved medication that was just approved this year, that's one of the successes. And there's others that's being researched. And from a cellular biology level, there are also what we call artificial pancreas for type 1 diabetes. So these are some stem cell research out there where because people's pancreas are not working, there are research groups that are figuring out how do we use stem cell technology to create pancreatic cells that function just like it would in a human body. And then how do we get that to people with type 1 diabetes so that it's much better controlled and less brittle than just using insulin therapy. And then there's a lot of technology-based research in type 1 diabetes, as I mentioned, with a lot of the hybrid closed loop pump therapy, along with the continuous glucose monitor. So those are what's happening with type 1 diabetes. In type 2 diabetes, I would say the most commonly studied right now are these similar to the Ozempic, Mounjaro, Wegovy, sort of this class of medication called GLP-1 receptor agonists. These are medications that actually enhance a hormone called GLP-1 that we all make through the gut system. It's called an incretin hormone. And we're seeing that not only does it help improve diabetes by enhancing our body's ability to make insulin, but also there's a lot of other effects that we are just now discovering or still trying to study exactly how it works in terms of reducing appetite through the brain and resulting in really sustained weight loss, actually pretty dramatic weight loss. And then, so there are pill therapies for GLP-1. And then also there are other, what I call like cousins of GLP-1 that scientists are trying to study and maybe in combination with what we're already using, some of these dual agonists or triple agonists, working that whole system and maximizing the benefit of that whole system in terms of both the treatment of diabetes and obesity. That's definitely very much in the works. And I think actually we can see an impact almost immediately. I think the pharmaceutical companies are very interested in those. So that means that we probably will soon have a lot more actual medication options to offer patients on this.
That's extraordinary and also quite wonderful to hear. I think that provides a lot of quality of life improvement for people that are currently living with diabetes, but those also that are going to end up being diagnosed in their future. So I want to thank you, Dr. Dewan, for joining me today and thank everyone for listening to this podcast about diabetes. To receive other women's health information, please visit A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter, read about upcoming podcasts like this one, to sign up for other upcoming free Conversations That Matter webcasts, and learn about in-person programs. So thank you for listening, and I hope you will join us next month for another special podcast featuring a Johns Hopkins Medicine expert. Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.